the medical director for kidney and pancreas transplantation at Loyola University Medical Center. She trained at the University of Chicago. She is an active participant in the National Kidney Foundation of Illinois programs and is on the board of the United Network of Organ Sharing. Welcome, Dr. Desai.
Hi, everyone. We'll keep this like just casual and low key today. My nurse manager, Maggie, was supposed to be presenting, but she couldn't make it, so I'm filling in actually for her. I'm gonna see if I can get this to work. They didn't instruct me on how to move to the next slide. I might have to get someone to help me with that. But today we're gonna talk about myths and facts about kidney transplant. And let me just see how this, let me go ask them real quick. Sorry, guys. Oh, no. Give me 1 second. Let me ask them. Sorry. They only told me to stand. Can you show me how to change the slides?
Oh, is there not a...
There's not like a, there's no little arrow or anything to move the slide. Or am I supposed to, am I supposed to use this? I thought I have to use this. No, this goes to that.
Oh.
So will this work?
There it is.
Oh, there you go. Okay, so I guess I'll stand like this. So,
you can press
sorry.
this right here as well.
Okay.
I don't know how far this extends.
Thank you, Mateo.
I would not use the screen though.
Yeah, I thought the screen was the driving force. So, sorry, today we're going to talk about myths and facts in kidney transplant. And so I wanted to first give some background on kidney disease and say that, we're not all alone in this process. The reality is in the United States, about 100,000 people are waiting for transplant. Of that, 660,000 people are actually diagnosed with chronic kidney disease, and only 100,000 are waitlisted for transplantation. 37 million people have chronic kidney disease within the United States, and 1 in 3 Americans are at risk for kidney disease. So a huge proportion of our patient population is unknowingly having kidney disease. Of that, 660,000 of us know we have it or are on kidney failure or dialysis, and only 100,000 of us actually get on the wait list. More than 1 in 7, or 15% of the US adults are estimated to have chronic kidney disease, and that's about 37 million people. And they are walking around day to day without knowing it. So how do we figure that out? We actually have to see our doctors, get diagnosed, and then understand the logistics of kidney disease. And so what are the common conditions that impact kidney health? And so I have them listed here, and you can see them kind of, I like this slide a lot because it's very circular and you can follow it. But the number 1 and 2 cause of kidney failure in the United States is actually diabetes and high blood pressure, okay? Diabetes, of course, causes damage intrinsic to the kidneys, and you start to spill protein in your urine. So if your doctor is telling you that they're seeing some protein in your urine, then that's abnormal, and if you have diabetes, likely coming from that source. High blood pressure, we know, especially in our Black African patient population, high blood pressure is extremely important and at times aggressive, and there's some genetic mutations and genetic diseases that cause for them. Heart problems and stroke. So every time our heart beats, about 25% of that blood flow needs to get to our kidneys. If we have heart failure, our heart pump is not pumping well, then our kidneys are not getting the blood flow that they need, and they begin to damage over time. Certainly, obesity or metabolic syndrome is a problem. Why is that a problem? Well, number 1, obesity leads you to have high cholesterol, which can lead to heart disease. It causes diabetes. And at times, the body mass is so much that the kidneys can't handle all that circulation and all that blood flow, and it can lead to protein loss and protein damage in your kidneys. Family history is something important to talk about. We have polycystic kidney disease as a cause of kidney failure. In our Black African American population, we see it's called focal segmental glomerular sclerosis, which is FSGS, which tends to run more common in that patient population. There could be HIV-related disease. There can be just diabetes, hypertension that runs within the family. There are other genetic issues such as IgA nephropathy, which is a protein and blood spilling disease. You can have a stone history in your family that causes problems and ultimately damage in your kidneys over time. So knowing your genetics is important, and really kidney disease is a disparate disease. There are many groups that are impacted more than others, specifically in our Black and Hispanic patient population. Believe it or not, smoking impacts your kidney function, right? So smoking actually causes our arterial walls to thicken a bit. And so if you're a chronic smoker, we can see that you begin to calcify a lot of your blood vessels, including your arteries to your kidneys, and that can cause kidney damage. And in fact, as we age, we lose some kidney function. And so when we look at ranges, we can see that about 35% more in our elderly population, 60 years and older, we'll see a lot of chronic kidney disease compared to younger patients. And so then what is end-stage kidney disease, right? Those are components of chronic kidney disease. You're going to manage that with your primary care doctor early on, and then hopefully a nephrologist later on. But when your kidneys ultimately fail, you're left with two options. This means both your kidneys don't work. You can't get your blood clean. Your blood pressure goes up. Your labs are abnormal. And so the options we have then are dialysis or transplant. And before that time, you're probably working with your doctor on the symptoms of kidney disease. And as some of you progress, or you may not be on dialysis yet, you may be feeling things like fatigue, nausea, tiredness, lethargy, nausea, vomiting, you don't have an appetite, you're losing weight. Those are all signs of kidney disease because it's a very silent disease until we move far out into almost failure, okay? And then what are the options then? So we're going to go through a couple of those, then we're going to go through the myths and facts. So it's hemodialysis is one of the options. You get a fistula placed in your arm, so you'll have an artery and vein connection, which is shown on, when you walk over, shown on the woman here. So this would be where you have the blood coming out, and then it comes back in once it's cleaned. And what you have here is the clean dialysis fluid, right? So the clean dialysis fluid is made or structured to be very similar to what our body should have as far as electrolyte balance. And the blood is moving in this direction. The dialysate moves in the opposite direction. And as they move like this, you start to have the toxins and the things that are abnormal move out into this side, and all the good things that we need as far as electrolytes and balance move in the other direction. That's done through osmosis. And then whatever's kind of the toxins and waste is put out in the dialysate fluid, okay? So that's one way to do dialysis. It's an in-center way many times. So you go to Monday, Wednesday, Friday dialysis, Tuesday, Thursday, Saturday dialysis, but now as we've moved on in the world of kidney disease, you could even do it at home too. And so there's different methods and different methodologies. The other thing you can do at home is peritoneal dialysis, right? So the blood is the source for hemodialysis, but the peritoneum, or the area or space within our abdomen, is the exchange module for peritoneal dialysis, okay? So rather than have a fistula, you're going to have a catheter placed in your belly. Fluid is going to go in, and then the small capillaries or blood vessels that are in your abdomen are exchanging across that osmosis pathway that we talked about, and then the bag drains out all the fluid once the exchange is done, okay? And that's a nice method because you could do it at home at night while you're sleeping, or some people tend to have daytime dwells as well, but it's a nice modality that you don't have to go in-center for. And then, of course, my specialty and my love is kidney transplant. And so what happens when you get a kidney transplant? Well, your own kidneys are here, right? They're back here. They're protected by your rib cage. We don't take them out when we transplant you. A new kidney actually goes down here into the blood flow down into your legs. So that's important to know as part of your workup, because if we find that the blood flow is hard into your legs, it's going to be hard to put a kidney. But that new kidney has its own space, and then the ureter, or the part that drains the urine, gets connected to the bladder. We don't ever touch your old kidneys. They stay in place, unless you have really large kidneys, like in polycystic kidney disease, where we have to remove them because we need the space to be used. The different types of transplant, of course, the blue side is about deceased types of transplants. So someone dies, and you get a kidney from them. On the yellow side, we have the kidney from a living donor, and you can see some of the differences here. So from a deceased donor, the kidney average time of lasting is about 10 to 15 years. While if we look at living donors, they actually on average last 20 plus years, right? We're more sophisticated in matching people. We can do it more correctly now with new technology. So we actually get a really longer sense of life with a living donor. Kidney patients on the deceased donor waiting list usually wait many years. The average waiting time in Illinois is about 5 to 6 years for a kidney transplant. And it's different based on your blood type. But if you have a living donor, if we clear your living donor and we say that they're healthy enough and you're healthy enough to move on to a transplant, oftentimes we can get that done within months to a year. And kidney patients who are deceased on the deceased waiting list tend to have more times for dialysis, and you don't know when the kidney is going to become available, right? But with a living donor, you're on dialysis until we work up that living donor, or maybe you're not even on dialysis. You don't have to be on dialysis to get a kidney transplant. If you have a living donor and your kidney function is 20% or less, we can still consider transplanting you, especially if you're not starting to feel well and you're having a lot of changes. So what are the myths and facts? So one of the biggest myths is that we think kidney transplant is a cure for kidney disease. I like to tell my patients that kidney transplant is a complex medicine. It's not curative in the sense of your high blood pressure is going to go away, your diabetes is going to go away, or even sometimes your genetic disease is not going to go away, okay? So what I like to tell patients is it's a way to come off dialysis. It's a way to extend your life. It's a treatment, right? It's not something that's going to cure your diabetes. Most patients will continue to have diabetes. Many patients, about 60% or more, still have high blood pressure issues after transplant. The only thing it could probably cure, in a sense, is polycystic kidney disease, because if you have polycystic kidney disease, it won't come back in your kidney transplant. So it's a treatment, not a cure. And even if you still have kidney disease and need to manage it a different way. So your nephrologists now become your transplant nephrologist. They help you with your diabetes, your blood pressure. We see you often. We make sure genetic diseases like FSGS don't come back in your kidney. Some diseases can come back in the kidney. And you're going to have to take medicines now, anti-rejection medicines, twice a day, every day for the rest of time. And we have different anti-rejection therapies as well, but the majority of patients are on the standard drugs, and they're twice a day, every day. One of the biggest myths is there are enough organs for those who need them. Now, we talked about this a little bit, right? 37 million people have chronic kidney disease. 660,000 are on dialysis, and only 100,000 end up with getting transplant. And so what we know is that if you're on the wait list, every 10 minutes, about 22 patients die every day because the organ they needed wasn't there. And this is much more challenging, of course, for our heart and lung and liver transplant candidates, because that's very life-saving. We have dialysis, we're fortunate enough to have that, so we can bridge you to transplant, but some of the other organs don't have other therapies that can support their life. And if we look at life expectancies for patients in the general population and those in dialysis and those who received a transplant, you can see that the lowest life expectancy is that red line there. And across the different age categories, it's lower than transplant patients, which is green, and general life expectancy for otherwise healthy individuals, which is the blue line, okay? Another myth is if you've been told you're not a candidate for a kidney transplant, you'll never be. We don't believe that to be true. So first, you need to know that you're lucky and fortunate to live in the Chicagoland area. You have about 7 different transplant programs that you can go to, and all 7 programs have different providers, and all different providers have different skills. So there are some programs that you may be told no at, but then you can find another program where they might be able to do a more complex procedure, or they're what we call a bit more aggressive in taking organs or accepting organs. You may also not be a candidate at this moment because you have some social issues or you have a medical disease that still needs to be corrected, right? If you come to us and we find that your heart function is not optimal, we might tell you to go see a cardiologist and get that worked up, get that corrected, and then you can come back and we can consider you for listing once you're healthy enough. The idea is we don't have organs for everyone. We want you to be at your best health so you can have a successful transplant outcome. If you're not at your best health and we try to transplant you, we're actually putting you at risk, and we don't want to do that for our patients. Different transplant centers have different criteria, so if one center has said no for whatever reason, you should still visit other centers and see if their criteria match. Are they, again, more aggressive, taking more complex cases? And then if you are told no, or you believe you aren't a candidate because of your age or medical status, you should know that some centers take on different categories of BMI, different categories of age. Some centers will take patients over 70, over 75. Some patients will take patients with BMIs over 40 because they have different surgical skills or technology at their center to help the patients. Another myth is sticking with dialysis is easier. It might be simple, right? You go every day or you do it at home. It's very convenient. After transplant, you're still seeing a lot of doctors, but the reality is your quality of life is going to improve with transplant. You're going to have increased physical activity and energy. You're going to feel better overall. You'll have a better social life, and you'll have more time in your life, especially if you're doing in-center dialysis or even home dialysis. You won't have those restrictions anymore. I like to tell my patients after 4 to 6 weeks, you should start living a little bit more normal and start driving and going out and kind of relaxing your lifestyle a bit. Another myth is you can't afford the tests, surgery, and medicines needed lifelong after surgery. This tends to be a very common thought process, but you need to know that every center has financial assistance, and every center has social workers and a financial team that can help work through those logistics with you. Okay, so it may take some time, but the idea is, again, to have you have a successful transplant. So they're going to work with you, build you up, talk to you about the different options that you have, and try to get you the care you need ahead of time so we can transplant you safely. You have to wait a long time for a kidney transplant. Before changes in about end of 2014, you were just waiting in line. And the longer time you had on dialysis, the longer time you had on the list gave you the option of the transplant. But it didn't make sense for someone to be 75 years old at the beginning of the line and get a kidney from a 20-year-old donor. So we, as a community, especially through the United Network of Organ Sharing, have made some changes to try to improve what we call equity or matching capabilities. In addition to that, remember we talked about living donation, and so living donation certainly expedites your process. Otherwise, you're still waiting a long time, especially in the Illinois area, for a kidney transplant. We've also improved our methods of what we accept. So you could accept a hepatitis C donor, believe it or not. Hepatitis C is now a curable disease. And so what many programs may do is offer you the hepatitis C donor that not everyone wants to take. But if you were to develop hepatitis C, which you will because you'll get exposed, then we can treat you afterwards with medicines and get rid of it. Some patients have the option of a hepatitis B donor. Depending on your blood type, there could be different blood types we could offer you. Even if you have HIV, you can still be transplantable nowadays. We can still work with all your medications, make sure everything's working fine for you. And so there are many options, and your transplant center is going to go through all of them with you. Believe it or not, if you're an adult who's maybe like 4'10" and less than 60 kilos, you could even get pediatric kidneys, and you can possibly get 2 pediatric kidneys transplanted, which equates, and they grow, and then you would have almost adult-sized kidneys. But there are many different types of organs we can begin to transplant. You can't have a kidney transplant if you've been on dialysis for a long time. That is certainly not true. And so, as we've talked about, you had to wait in line before. The longer you were actually on dialysis, the more likely you were to get the deceased donor kidney. And now with some of the changes, you're going to be offered kidneys 15 years younger than you, 15 years older than you. There's many, many changes in the calculators and the numbers, but dialysis vintage time or how long you've been on dialysis shouldn't factor at all on whether or not you're a transplant candidate. We're really trying to make sure you're healthy enough for the transplant process. And if you've never been evaluated and you come and you've had 15 years of dialysis behind you, that's okay too. If you're still healthy enough to be transplanted, the minute we clear you, you're going to get a transplant because you'll be at the top of that list. I like to show this to give you that sense of how important is it to begin to work towards that transplant process? So the orange here is dialysis patients, and the blue represents patients who have been transplanted. And as we look on the age axis, which is that y-axis, you can see it starts at ages 20 to 24 and goes down to 75 to 79. And then the bottom x-axis is how many remaining years of life will you have if you continue on dialysis alone versus if you get your transplant. So let's just look at the age 20 to 24 at the top. If you were to be on dialysis, at the younger ages, we're more resilient, our bodies can take on more, and you may have 17 years of life on dialysis. But if you were to get a transplant, you would actually have almost 45 years of life ahead of you. And even if you're 75 to 79 at the very bottom, you can see we're not as successful with dialysis as we age. Our bodies can't really handle that wear and tear. But with a transplant, you're still going to add about 10 years of life to you. So in every age category, for every group, we should recognize that transplant is the primary option. Another myth, if any of you do have living donors, is that donating a kidney is a dangerous procedure. I mean, I get worried if I have to think about surgery. I don't know that I'd ever want a surgery for myself, but surgery is surgery, and it sounds like it's very risky, right? But the reality is, as most donors will go home probably the next day from the center. The surgery is a surgery, so it's not without risk, right? You may have some bleeding complications, which is rare. You may have infection. You could have even a small risk of death. The risk of death is about 0.003%. But the most common complaints we would get from donors is that they feel bloated. The belly has to be inflated to get the kidney out. They have some, constipation, which is from pain medicines. In general, they do very well, and it's a very low-risk surgery. Out-of-pocket expenses for your donor are going to be too high, and that can be a legitimate concern. Donors have to take time off of work. They need to make their finances at home. The reality is there's some safety nets for donors, and we recognize donors for the altruism that they're doing. So the recipient insurance, so if I needed a transplant, my insurance would cover my donor's workup. And there are protective shields that can be offered to patients too that give some legal support, lost wage reimbursement, travel and lodging as well. Because now that we've become so sophisticated in matching, your donor doesn't have to come from right within the area, right? You could say that my son lives in California and I would like for them to donate, but logistically it might be hard for them to come here. We can work out methods and means to actually work with the center there to then bring the kidney over here, okay? And that members of the transplant team will pressure someone to donate. So that's an absolute no, we don't do that. And the reality in donation is that it is something that is totally of the free will of the donor. You could tell me today that you have a donor, and you could give me their name and you could give me their phone number, but I'm not going to call them, right? So what has to happen is the donor has to call us first. They have to integrate themselves, and they have to make that first move. And at any point in time, I tell donors when I see them, if you feel uncomfortable or this is not for you, even if we're taking you to the operating room, believe it or not, this happened to me once. It was the day of the operation and the donor just didn't show up. And it's okay, you get scared, it's a different thing. And for the donor, it's a life-changing thing in that, you can't put the kidney back once you take it. And so we respect that. We honor that, and it's okay to feel any way that the donor wants through the process. And they have protective measures. So we have a living donor advocate that sees the patient. They also see a social worker to make sure that they're comfortable through it. And donating, so then there's myths about the donors themselves. What happens to them? So it reduces the donor's life expectancy. We have lots of data here showing, and through lots of literature, that there's no difference between a donor and a non-donor as far as life expectancy. So non-donor is actually the dark line, and you can see the light line, which is donor, and there's no changes in their life. That no one will volunteer to be a donor. I get that a lot. Someone will come, I don't know, nobody said anything to me. I haven't talked about it. So first and foremost, you have to be your own advocate. You need to go out there and tell them that you're having kidney disease or you're on dialysis, because otherwise no one will know. We don't physically show ourselves as being sick a lot of times as we have kidney disease. But since the first successful transplant, we've had 50,000 people become living donors, and about 6,000 living donor surgeries happen yearly. And now with the sophistication that we have with matching, anybody could be a donor. So it doesn't have to be your family member. It doesn't have to be someone even related to you. It could be someone in the community, a friend, someone that's at church with you, someone that works at your job with you. And as long as they're willing to donate on their own will, we can work them up and look at them. Okay, but the most common donor still is a spouse, believe it or not. After surgery, donors won't be able to have children. That's a common myth. And there's no evidence to support that kidney donation impacts your ability to have children. We talk about that openly. The only thing is if you're a female donor and young and you're still planning to have kids, we do have conversations about maybe some high blood pressure or protein during the transplant, after donation, because there's one kidney to kind of take on all that fluid that we take on as women when we're pregnant. Donors need to be a family member, and I said this is not true, so I really like this. So here's 2 different ways that we can exchange kidneys nowadays. The very first transplants were done from identical twins, because we didn't have any anti-rejection medicines to help you out. But now we have lots of anti-rejection medicines, but you still have to match. So you can't be completely different blood types and then try to donate to each other. Your kidney would reject. What you guys see here on the left side of the screen is what we call a donor chain. So if you look at the top corner there, you'll see the pair. They have names, Chelsea and Wanda. And so Chelsea and Wanda can't donate to each other. Let's say that Wanda has a different blood type from Chelsea. Or sorry, Chelsea has a different blood type from Wanda. But Wanda matches the person right next to her, right? So this recipient B. And then the other donor matches the next person, and the other donor matches the next person, and we go on and so forth. And then at the end, the last person on the chain becomes Chelsea, and Chelsea finally gets a kidney, okay? So it's basically like almost like a pay-it-forward system, and we work through that logically at the centers or even with other centers. We have a National Kidney Registry that helps us to determine pairs. A very simple one is what you see here, where you just have a mother and a son and a wife and a husband. And the son can't donate to mom, and the husband can't donate to their wife, but they can do it the other way. And that's just a paired exchange. There's so many names. Paired exchange, swaps, donor paired exchanges, but they all mean the same thing. It's a pair of people who are committed to the process, and ultimately you'll still get a living donor. Another myth is you can't get transplanted if you are uninsured. That is certainly not true, especially in the state of Illinois. We do have methods and means to help assist you in getting transplant insurance, transplant care coverage. And there have been some policy changes in the last year that even afford getting your medication coverage and stuff as well. So you should talk to each individual center and see what options you have, what policies there are. And then the transplant evaluation is short clinic visit. That is certainly not true. So when you come to see us in clinic, you're going to see a team. You're going to see a nephrologist, you might see a surgeon, a social worker, a financial counselor, a pharmacist, and then your own coordinator, right? So you'll have a coordinator that sets up. So your day is really long. We tell you to bring some food and kind of be prepared. And some centers might do the whole workup, and it's a whole day-long process. But what we tend to do is we have a half-day clinic. You'll see, you'll get education, you'll see the physician, and then you'll see social workers and everybody else. And I think those are all the myths I have. Yes, so any questions? I covered a lot. How many have chronic kidney disease in the room? And are you on dialysis? And are you listed somewhere? And that's going smoothly, no issues? Any questions on that process? It's not an easy process. No. And what about everybody else in the room? Who has chronic kidney disease, or you have been diagnosed recently with some disease? Transplant. And when was your transplant?
June 2016.
Okay, wonderful. And everything's going well? You seem to know when I said FSGS, so is that your primary diagnosis? And they've been watching you and things have been successful. And then what about? Transplant. Transplant. And where was your transplant? At Rush. And when was that? 2002. And everything's been going okay? Yeah. Any questions since? Good. And then in the back of the room? Oh, you're working, okay.
Kidney transplant and pancreas transplant
Wonderful.
back in July
Okay,
2021. I'm losing track of dates.
okay, awesome. And doing well?
Knock on wood.
Good, good. Good. Lots of,
Can I ask you a question? The FSGS,
mm-hmm,
a few years ago at a seminar like this,
mm-hmm.
they had said that they really still don't have all the research on that.
Yeah.
Is it still that way now, or?
So we've actually, when I was speaking to gene mutations, we've actually found a gene that makes especially our African Black Americans more susceptible to FSGS or HIV-related kidney disease. And it comes from, believe it or not, a protective measure to prevent sleeping sickness. That runs very heavily in Africa and impacts our African American patient population. So there's a fly called the tsetse fly, and it carries a parasite. And if you get exposed to that, then you can get the African sleeping syndrome. But over time, our bodies have evolved to create gene mutations in a gene we call the APOL1 gene to prevent the African sleeping syndrome. So if you have one gene and not the other, like one knockout, then you won't get as sick. But if you have both of them knocked out, then you're at a higher risk of kidney disease. And so we are now studying that gene across the nation in donors and recipients to see how that impacts their kidney function. So there's actually a national study, it's called APOL1.
So are you saying that a fly can cause that? Is that what you're saying?
The fly has a parasite, and if it bites you, then you can get exposed to the parasite, and that causes an African sleeping syndrome. But our bodies have created gene mutation to make it so that if we get bit or get exposed, we don't get as sick. Yeah. But then if you get both mutations, then you can get FSGS more prominently. And you can have, if you had HIV, you can actually have HIV-related kidney disease more prominently as well, and certainly more chronic kidney disease. And so we're studying that right now. But that's something new in the last probably like year or two. COVID put a little bit of a damper on that. But there's a national study going on with it.
I do have a question.
Yeah.
I have tested positive for the BK virus.
Sure.
And I didn't know much about it.
Uh-huh.
My number is going down now.
Okay.
Finally. Do you have any comments about it?
Yeah.
Or what I should do?
Yeah. So BK virus is it's a form of polyoma virus, and it's basically BK stands for the initials of the person that found it. What happens, it's similar to kind of when we get chickenpox when we're young, and then as we age, we develop shingles. So that herpes virus, when we get chickenpox, falls asleep oftentimes in kind of the nerve roots. And as our immune system gets suppressed, it can flare and we can get shingles. BK virus is a similar concept. So probably 8 to 9 out of 10 of us get exposed when we're young. It kind of hibernates in the bladder wall lining. And as your immune system gets suppressed, which we have to do for all your anti-rejection medicines, then the virus can flare. And it's not a problem at low levels, but if it gets high enough in the blood, it can get into your kidney transplant. And the mere nature of that virus being there causes inflammation, and ultimately you can start to lose your kidney function. It's not going to cause you to be sick, though. You're not going to get pneumonia or diarrhea or GI symptoms. You won't necessarily feel that you have that virus. But we as nephrologists worry because if it's too high, then it can impact your kidney function. So probably what your doctors have been doing is very hard in kidney pancreas because we want the pancreas to have the right amount of immune suppression, but they're probably reducing it to help get rid of the virus.
Probably, I had that too.
Did you?
And they went down on my
Mhm.
anti-rejection medicine.
Yeah.
They did drop mine, but my BK numbers were still going up. And so then they responded with IVIG treatment.
Mm-hmm.
And now they've stopped that, and they just want to monitor
Okay.
the number. And I will say, my last blood test, it was much better than it's been since like November.
That's good, yeah. Anything else, guys? Well, thank you. Any transplant questions? That's my job. Is there anything in your workup that's like remaining, or you're on the list active, just waiting for your offers?
I'm on the list after waiting for my offer, but it's just a little difficult for me because I did have a living donor, but
Mm-hmm.
I have antibodies in my blood,
Yeah,
so that's the
that
reason
makes it
why we
hard.
didn't,
Yeah. And that's the challenge still for all the centers. There are some centers that do try to desensitize patients. I don't know what center you're at, but some centers, like Northwestern, look at desensitization protocols. I know University of Chicago is looking at some protocols too. I don't think they have anything fixed in their plan, but certainly there are centers that could look at those things for you. And that's why I'm saying some centers have more technology than other centers, and you should look at as many centers as possible. If you're on the list at one, it may seem like it doesn't make sense to be on the list at another center, but we do have surgeons at different centers, and some are more aggressive at accepting organs. And so it is also worthwhile to talk to the surgeons to see, how do you accept organs? How aggressive are you and stuff? Okay. Well, I'm here. I'm thinking moderating the next thing. So if you have questions, come and ask. But always feel free to come up too if you want to talk about anything. Thank you, everyone.